Hello, everybody, and very welcome to the 2023 DOPPS Spring Update meeting. We're going to have today another remote meeting that is very similar in intention to the spring and autumn update meetings that we had in the past, presential in the congresses of the American Society of Nephrology and the yearly DTA. And as there's a tradition, we will be also presenting three different sessions, one on each one of the studies I will present later to you. My name is Roberto Peguá Filho. I'm the DOPPS Program Scientific Director, and I will have the pleasure to coordinate the session with the moderators and the presenters that I will introduce a little bit later. Have the next slide, please. I will start by acknowledging the funders of the DOPPS program. Over the years, the DOPPS program was possible with the support of a combination of industry funders and also public funders. Our sponsors are listed in the slides, and we would like to start the session by acknowledging their contribution to the program and also thanking very much for the support. Can I have that? Thank you. So other, of course, than this list of supporters, we would like to also give our thank you to all of you who made the DOPPS program possible since 1966. So it's been more than 2 decades that DOPPS has been around, collecting data and presenting data to the community, and really we hope that we have had an important impact in changing the clinical practice in chronic kidney disease, hemodialysis, and peritoneal dialysis. So thank you very much, our country investigators, and especially our research coordinators, site investigators, and obviously all the patients who have been volunteering to participate in the study. I also would like to acknowledge in the beginning of the session the collaborations that we have had with the International Society of Nephrology. So over the last few years, the ISN and DOPPS contributed to a series of activities, both from an education perspective and also some research collaborations. And I wanted to highlight that there's been educational activities done and delivered through joint webinars, podcasts, video abstracts. And I would like to also mention that all of this content produced in the past 2 years is available at the ISN Academy platform. I wanted to also highlight our collaboration with the ISN in research recently, with the publication of a series of papers that summarized our survey in a vast geography and a large number of sites across the globe in collaboration with the ISN, with a real focus on low and middle income countries and the impact that COVID has had on dialysis services, both in hemodialysis and also in peritoneal dialysis, which has really generated an interesting series of papers that I think contributed to the community to understand the impact of the pandemic on dialysis services across the globe. Also wanted to mention that as a continuation of the collaboration with the ISN, the recording of this spring update meeting will be available at the ISN Academy, like the other educational contents that I mentioned just a few minutes ago. This is the description of the current numbers of the DOPPS program worldwide. You can see here that over the last few years, we've had a very global presence, and we were able to collect data in a number of clinical sites and from a number of patients across the globe, which has helped us to really be able to publish our research across this decades of activities. This is the list of publications that we had across the years. It's very, very interesting to see the constant number of papers published in the main journals in the area of nephrology and internal medicine more in general. If you look at the numbers of publications across the years, you can really see that the number has been quite stable, and we keep publishing quite vastly over the years. If you look at the average of publications that we've had over the decades of the existence of the DOPPS program, we've published an average of almost a paper per month across more than 2 decades of activity, which I think it's very impressive. I also think that perhaps not only the papers are important, but all of the repercussion of DOPPS data. And I think these publications have had a very impressive number of citations and impact in policy changes, guidelines, and I think really this, after all, has generated information that has been very valuable to the community and has caused an important impact in making clinical practice in kidney disease and advanced kidney disease in a very impressive way. See the next slide. Well, let's now talk a little bit about the future and review some of the study goals at this phase and moving forward. So the ongoing program goals for the DOPPS program are very similar and aligned with the history of DOPPS. We will continue in the future describing real-world practice variation in different countries and identifying the practices that are associated with the best outcomes. And we also continue interacting with the community to serve as a resource to the community, both from the perspective of an investigator, but also from the perspective of stakeholders that are responsible for the development of new therapies. There are some additional and more specific goals for the next phase of DOPPS starting this year and in the next wave that traditionally would have the duration of 3 years. In this phase of the study, we really will focus on studying and better understanding the transition period from advanced non-dialysis chronic kidney disease to dialysis. We will continue with the focus, but really update our capture of new medications and technologies. I think nephrology goes through a revolution in terms of new medications and new technologies, and DOPPS will continue to capture the early experience and the impact of introduction of new therapies in the real world and its impact on patient outcomes. And as we did in the past, we will continue capturing the patient experience through questionnaires that we started to use in our studies many years ago, and we'll continue doing that with a change that will shift to a collection of questionnaire in an electronic format just to facilitate data collection and to reduce the burden to patients responding the questionnaire, investigator, and study coordinators. This is the main change that you can expect to see in the DOPPS program during the next few years. So we will focus on transition from non-dialysis chronic kidney disease, and we'll continue to capture data on patients starting dialysis, both hemodialysis and peritoneal dialysis. The DOPPS program will become more flexible, and it'll be flexible to implement a single study like DOPPS, like PDOPPS or CKDOPPS in some countries, and in other countries, and we'll start seeing that already this year for Europe, we will be able and we will implement a combination of studies that could be patients in non-dialysis, in hemodialysis and peritoneal dialysis with a new protocol that we are calling the transitions protocol, which will be enrolling patients in the non-dialysis phase and follow up these patients through the transition to dialysis in clinics and settings that can capture that transition under the same system. I think the transitions protocol meets a major unmet need in the kidney community. Very few studies looked prospectively and under the same protocol, this transition from the non-dialysis phase and the dialysis phase. And I think this will allow for a very important contribution to the understanding of this transition period, and also would allow for the development of specific and ancillary studies. One example that we can mention is what's going on in the UK, that will be aligned with the transitions protocol. We'll have a study on cognitive function comparisons between hemodialysis and peritoneal dialysis that will be built on top of DOPPS and PDOPPS, and you'll be capturing incident patients that were followed up even before patients transition into dialysis. But one thing to highlight is that feasibility is our focus, and we do want to start with the transitions protocol in Europe and expand both in terms of geographies and also expand in terms of number of sites and number of patients. We'll pay attention at site selection, and we'll respect staff availability and trying to guarantee a nice and smooth patient flow across the studies. We'll continue searching for funding for for the introduction of the studies in different areas and regions. And we count on our local investigators to help us in the fundraising activities. Well, this session today is the beginning of what we wanted to be a combination or a hybrid remote and face-to-face activity. So we will have the presentations today and some discussions, but we will continue the discussions especially for those who will be joining next week the ERA-DTA conference in Milan. And would like to invite you all to a social and scientific event where we will continue the discussion that we had today in our DOPPS social mixer. That will happen on Thursday, June 15, at the Milano Hotel from 5 to 7 p.m. Okay, so now it's time to move to our scientific program for today. So as you can see here in the description of the agenda, we'll have 3 blocks, each one of them representing or presenting data in each one of our studies. Starting with our DOPPS presentations, we have 3 original presentations for each one of the studies, which will be moderated by Ron Pisoni, Mark Lamby, and myself for DOPPS, PDOPPS, and CKDOPPS respectively. Have the next slide, please. So just a few housekeeping messages to you before we start. First, I wanted to remind you that the presentations that we'll have today, they are pre-recorded. And when the videos will play, if you're joining via your phone, the audio from the video will be playing from your computer, not the phone. So please turn your computer audio up when we are presenting the video presentations. You can see in our webinar platform that you can ask questions through the Q&A panel, and we will make sure both the moderators and speakers are joining us today. We'll make sure that we will address all your questions as the presentations go by. We'll have a time for discussion at the end of each one of the blocks. So Q&As for DOPPS, PDOPPS, and CKDOPPS were done right after the individual presentations. See the next slide. So with that, it's my pleasure to pass the mic to my friend and wonderful investigators from DOPPS, actually one of the founders of the studies and the initiatives, has been around since the very beginning of DOPPS, Ron Pisoni, who's a distinguished research scientist here at our Research Collaborative for Health. And I invite Ron to moderate the first block of presentations about DOPPS. Ron? Ron, if you're trying to speak, maybe you're muted. I can't hear your voice now. Well, while Ron is fixing the technical problem, maybe I'll just kick off the presentations for the DOPPS program, and Ron will join later for the for the discussion. So may I have the next slide, please? So this is DOPPS, the last phase of DOPPS, which is finalizing this year. And it went on in 14 countries, more than 400 sites, and more than 40,000 patients. You can see here in the map the participating countries in DOPPS, and the seventh wave of DOPPS from 2019 and 2023. Next slide. This is a list of our country investigators. You see how much it takes. It really takes a village. And I think here you can see a list of the names of people who are really responsible by interacting with us in the organization and implementation of the study at the site level, and also building the scientific agenda and contributing to the publications generated by them. Next slide. Some important partners for DOPPS needs to be acknowledged. These are data hubs that use country data that represent an important activity. We are not able to really explore all the data, and we welcome the participation of countries who would have the capability to carry analysis on their own. And this is a list of 3 of the important data hubs that have been working on data from Canada, China, and also in Japan. And I would like to thank our investigators for all their efforts in analyzing local data and publishing the results. Next slide. So with that, we just now we move to the presentation themselves. The first presentation will be by our own Jung-Hui Zhao. She's here from Ann Arbor Research, and she's going to present the data that she led the analysis, which is the impact of ethylcalcitrate discontinuation on PTH levels in the US hemodialysis patients. Let's hear from Jung-Hui.
Hello everyone, the topic I'm going to talk about is calcimimetics reimbursement changes in 2021, impact of ethylcalcitrate discontinuation on PTH levels in US HD patients. The background, calcimimetics, including ethylcalcitrate and cinacalcet, are often prescribed to HD patients to prevent complications of high PTH levels. Prior to 2021, calcimimetics were not included in dialysis payment bundle, which means providers would charge extra if calcimimetics are prescribed. Starting from January 2021, calcimimetics were included into this bundle, and a $10.09 per session was added to cover this, regardless of whether patients are taking ethylcalcitrate or not. We suspect that this policy change would impact calcimimetics prescription practice, and we don't know how this will impact MBD markers. So the objectives of this analysis is to analyze the impact of ethylcalcitrate discontinuation on the trajectory of MBD markers, and to look at whether ethylcalcitrate discontinuation impacted PTH control differently in Black versus non-Black patients. We use data from about 23,000 US HD patients from the DOPPS, and among patients who discontinued ethylcalcitrate between December 2020 to April 2021, which is the period that discontinuation was more likely driven by policy change than patient indication. And we looked at within-patient changes in PTH and other MBD markers in the 6 months before versus 6 months after ethylcalcitrate discontinuation, and compared those using linear regressions. Slide shows the prevalence of ethylcalcitrate and cinacalcet prescription. we see that the ethylcalcetide use decreased from about 12% to 5% after January 2021. In the meantime, cinacalcet prescription increased over this period. And we see there's even a bigger change for Black patients versus non-Black patients. This slide shows the proportion of patients on ethylcalcetide who discontinued. We see that there's a spike between December of 2020 to April of 2021, and we think that ethylcalcetide discontinuation peaks are more likely driven by policy change than patient indication. So we choose 750 patients discontinued between this period, and from that, 713 patients were having at least 2 MBD measurements in both pre and post 6-month periods. So those 713 patients will be used as our study sample in this analysis. Looking at patient characteristics, the average age is about 64 years old, sex 55% are male, and about 48% patients are Black patients. This slide shows the mean PTH among patients who discontinued ethylcalcetide. PTH levels were about 570 before ethylcalcetide discontinuation, and this increased to about 700 afterwards. A bigger change in Black patients, their PTH level raised to about 750 after ethylcalcetide discontinuation. Looking at PTH greater than 600, the prevalence increased from about 28% before discontinuation to 43% after discontinuation. Higher changes in Black patients, their prevalence of PTH greater than 600 raised to about 50% after the discontinuation. This slide shows the mean serum calcium among patients who discontinued ethylcalcetide before and after discontinuation. The mean calcium is about 8.7 before discontinuation, and this increased to about 9.2 afterwards. This slide shows the dichotomized serum calcium. The orange line shows the serum calcium less than 8.4, which the prevalence decreased from about 30% to 15% after the discontinuation. This slide shows the mean phosphorus among patients who discontinued ethylcalcetide before and after discontinuation. There's a slight increase of phosphorus after the discontinuation, then slightly decreased afterwards. Similar story for phosphorus greater than 5.5. In this outcome analysis slide, you can see that the pre-column is calculated as the average of 6 months value prior to the discontinuation, while the post column corresponding to the average value for 6 months after the discontinuation. The adjusted differences shows the adjusted results in linear models adjusting for age, sex, vintage, Black race, comorbidities, and albumin. We see that on average, PTH increased by 106 after adjustment, and calcium increased by 0.42, and phosphorus increased by 0.16. Looking at the dichotomized PTH levels, we see a 15% increase of PTH greater than 600. In summary, from July 2020 to July 2021, ethylcalcetide use decreased from 12% to 5% among the 700 13 patients who discontinued etoposide between December 2020 and April 2021, the prevalence of PTH greater than 600 increased from 28% to 43%, and there's an even bigger change in Black patients. Mean serum calcium and phosphorus levels increased by 0.42 and 0.16 respectively. Adjusted model results were consistent. In conclusion, in the US HD setting, etoposide use decreased substantially following the end of TDAPA designation in January 2021 in spite of the increased bundle payment. We observed a swift and a sustained impact on PTH levels, especially among Black patients, raising concerns about disparity and potential downstream impact on clinical outcomes. With that, I'd like to thank you for all the authors who have been involved in this analysis, and thank you for sponsor, and thank you for everyone's attention.
Thanks so much, Junhui. That was a very nice presentation, and I think this type of study really shows, the potential of DOPPS capturing changes in practice. This was focused in the US, but obviously this could be done anywhere, and I think this is it's an interesting experiment in a way that might offer really an opportunity to understand it, not only the impact of implementing therapies, but also the impact of discontinuing therapies. And we'll have Junhui with us at the end of the session to discuss the presentation. So with that, I'll pass to the next presentation. So we'll have Angelo Carboyes, also from Arbor Research. Angelo is a research scientist and epidemiologist here in Ann Arbor, working with us for many years, and has led this very interesting study that he's going to share with you, titled "The Red Blood Cell Transfusions Rates in Non-Dialysis, CKD, Hemodialysis, and PD." That's it from Angelo.
I'm Angelo Carboyes, an epidemiologist and biostatistician at Arbor Research, and I'll be speaking today on red blood cell transfusion rates across the DOPPS program area. Before I jump in, I first wanted to disclose that the funding for this research came from GSK, as well as acknowledge contributions from all of our co-authors, most notably Charlotte, who performed all of the analyses for the project. International guidelines recommend treating patients with iron and ESAs to target hemoglobin levels and avoid transfusions whenever possible. This is because there are short-term and long-term adverse consequences of transfusions, perhaps most notably allosensitization, which may impact patients' ability to receive a kidney transplant. So a contemporary view of transfusion rates across non-dialysis CKD as well as dialysis patients on HD and PD is needed overall and by key strata that include CKD stage, dialysis modality, dialysis vintage, geographic region, anemia factors including hemoglobin levels, ESA and iron use and dose, as well as other potential risk factors including comorbidities. The two objectives for this study are first to estimate transfusion rates overall and by patient subgroups that were described earlier, and secondly to identify patient level and facility level risk factors for transfusions. For the study, we utilized data from all three of our studies in the DOPPS family, CKDOPPS, PDOPPS, and DOPPS, and we took advantage of uniform and standardized transfusion capture across these studies, as well as across countries within these studies. This ensures a fair, unbiased comparison of rates across all strata of interest. How was transfusion captured in the DOPPS program? You can see on the screen here the excerpt from our interval summary questionnaire from every 4 months, and the study coordinator completed the form which asked, did the patient receive a blood transfusion in the first, second, third, or fourth month during the interval? So we'll know, yes or no, as well as the number of units that were transfused. We then take the total number of patient months with a transfusion event divided by the total number of patient months with transfusion data available. We can then take that rate, convert it to per 100 patient years, and estimate 95% confidence intervals using Poisson regression. This presentation will show a very limited amount of preliminary data. You can see here the transfusion rates in the HD study in DOPPS by each country. The transfusion rate in the US was about 20 per 100 patient years, but you can see the substantial variation that we observed across all of our DOPPS countries, with transfusion rates ranging from less than 10 in China to over 40 in Belgium and Sweden. For a more detailed presentation of results, I would encourage you to check out our focused oral presentation at the upcoming ERA Congress. If you are able to make it to Milan for the Congress, our presentation will be on Friday, June 16th. If you are unable to make it, that information should be available online, where you can see our e-poster we've created with content, not only our HD study, but also showing transfusion rates across countries in PD and non-dialysis CKD. We also explored how transfusion rates varied by hemoglobin levels in each of these 3 studies. More recently, we've submitted an abstract to ASN where we explored transfusion rates in the dialysis population, exploring how transfusion rates varied from dialysis initiation through the first couple years of dialysis, and compared and contrast patients who initiated hemodialysis versus peritoneal dialysis. Still to come, we need to identify patient level and facility level risk factors for transfusion and a more formal statistical analysis. Ultimately, we plan to develop a manuscript that focuses on a contemporaneous global perspective on transfusion use across the non-dialysis CKD, PD, and HD populations. While performing this analysis, we also realized some of the limitations of our data capture. And so we went back to our interval summary and decided to update the way we captured transfusion use moving forward. And so for phase 8 of DOPPS in Europe, we've added the primary and contributing causes of transfusion. You can see here on the screen the list of options that we offer, where study coordinators can indicate reason for transfusion was due to GI bleed, other bleed, anemia factors, or any number of other factors included on the list. And so while information on whether or not patients received a transfusion, yes or no, is certainly helpful to inform the scope of the issue and rates of these transfusions, being able to understand reasons
Thanks very much, Angelo. I really think that red blood cell transfusion is a topic that it's so important for the reasons you outlined in your presentation, and it's very interesting to see, the analysis of DOPPS data. What calls my attention about the study is really the fact that, using a very similar protocol, it's possible to really describe not only transfusion rates across the different studies, but also across different regions. I think this is a unique characteristics of the data you presented, and I'm really looking forward to see, some of the future analysis that will be done in the same project. So thanks, and I'm looking forward to the discussion. Joining you in the discussion in a few minutes. Okay, so with that, we transition to the last DOPPS presentation. That is going to be presented by Xinju Zhao from China. Xinju has been working very closely with us and with Chinese investigators under the leadership of Dr. Zhao Li, our principal investigator for China. And this study that she's going to be presenting is a result of a project that she has led, and that's a very interesting observation of platelet count and the U-shaped associations with mortality in hemodialysis study that she observed. So with that, let's hear from Xinju.
Hello everyone, my name is Xinju Zhao from Peking University People's Hospital. It's my pleasure to present our most recent study results. The topic is about platelet count has a U-shaped association with mortality in hemodialysis patients. As we all know that mortality rate is much higher in HD patients than that of individual in the general population. And diverse risk factors for death has been identified, including older age, hypertension, diabetes, and others. Platelet count is a component of our clinical routine assay. However, platelet plays not only a crucial role in the coagulation, cascade, clot formation, and wound healing process, but also studies have suggested that platelet also serves as a biomarker for inflammation and atherosclerosis. Hence, we suggested platelet maybe have some association with mortality. In general population and some diseased population, they also suggested the association. So previously, we have published a research. We found that thrombocytopenia predicts mortality. And maybe platelet count can be served as a useful prognostic biomarker for clinical outcomes. However, that study has some limitations. The first one is patient groups. The participants were only divided into two groups as a thrombocytopenia group and a non-cytopenia group, which was limited by the small number of patients with higher platelets. Another limitation is it's Chinese HD patients only. So we want, in order to address these limitations, we want to include more patients. So we use the international data from DOPPS phase 5 data to explore the association of platelet counts with all-cause mortality and CV mortality. The participants were divided into three groups according to their platelet count as low, normal, and high platelet associations. And we use Cox regressions adjusted for confounders. Altogether, we included more than 13,000 patients from 15 countries and areas, including Australia and New Zealand, and also Gulf Cooperation Councils. As we can see here, most patients were in a normal platelet group, and 600 patients in low platelet group, more than 1,000 patients in high platelet group. The median age was 65 and with male predominant, and the dialysis vintage was 1.9 years. The leading primary kidney disease was diabetic nephropathy. The mean platelet count was 200 overall and ranged from 173 in China to 227 in Sweden, with most patients in normal platelet group. Altogether, there were 70.2% patients died, and 75 were from cardiac and vascular disease, and followed by infectious disease. That is, the mortality rate was 10.9 per patient per 100 patient years. And of course, we can see the mortality rate was higher in both low and high platelet groups compared with normal patients in normal platelet groups. Here is the 5 incremental adjustments for all-cause mortality. We can see the U-shaped trend. And here is the full adjusted model, and we find that both low and high platelets were associated with higher all-cause mortality after adjusted for covariance. And for low, the hazard ratio is 1.5, for high is 1.2, and CV deaths also have the same trend. And we also did the subgroup analysis. We can figure out from this forest plot for high versus normal platelet group and low versus normal platelet group. And we can find that for most subgroup, the trend is true, both high and low platelet can be associated with a higher mortality rate. And we have submitted this result to ASN. Hope it can be accepted as oral or poster. And we have some other interesting analysis, and this one was also has been also accepted by renal failure, and this is about high facility level serum potassium variability. We found it's associated with mortality in HD patients. Here, in all the 6 models, it has statistic meanings. And we also has this draft manuscript about influencing factors of ERI and its relationships to all-cause mortality in HD patients. And here we can figure out that ERI and all-cause mortality, it predicts all-cause mortality, but not CV mortality. And that's all for my sharing. Thank you for your attention.
Thank you, Xinchu. It's a really excellent presentation, and actually from all of the speakers, I think there are just so many different interesting research projects going on here, and just really want to thank all of the presenters so much. We have a few questions that we thought would be interesting to ask, and so Jinju, maybe if I could start with you. I think this is such an interesting study, the platelet study, and showing that folks who have thrombocytopenia, well, the U-shaped relationship, right, across the different levels, the different platelet levels, and here, even with all of the adjustments that you've shown, and you know, whether it's adjusted for comorbidities and cancer and albumin, and you know, it really holds up very strongly across all of those, and so it's really, I think, a novel predictor that you know, typically hasn't been used much in analyses. And I was just wondering, you showed in your that in the crude level data that there also appeared to be a higher risk of infection-related death. And I was wondering if you've looked at that further in adjusted models, or infection-related hospitalization or mortality, and if that what you've seen maybe in those kinds of models.
Yeah, very good suggestions. We haven't done that. Yeah, maybe you're right, because platelet sometimes can be served as an inflammatory marker. So maybe have associations with infectious disease, mortality, or hospitalization. Yeah, maybe next stage, yeah, we can try to do the analysis.
Yeah.
Thank you.
Oh, that would be interesting. And for any, you know, I know CRPs are collected in some of the countries, and I guess that would be interesting as well to see what kind of relationships one sees with CRPs. You know, I noticed that the patients who have low platelet counts are older, of longer vintage, for instance, and just wondering if one looks from the start of dialysis, when one starts seeing patients, or how long patients, when they become thrombocytopenic, how long patients typically, you know, is there much fluctuation from having thrombocytopenia and or once maybe infections are improved upon, then maybe patients then their values return to a more normal level. But I guess understanding how long patients remain thrombocytopenic within the hemodialysis patient population, I think, would be interesting as well.
Right. Platelet is on the biomarker. I think we should like recognize the underlying disease behind this marker. Yeah, why it's high or low, and then if we can correct this underlying disease, patients may have better survival. Yeah, right.
Yeah.
Thank you.
Thank you. Yeah. I just had one other question, and that's with regards to your facility level variability in serum potassium levels, which also is very interesting. And I was curious whether you've looked at then in facilities that have greater variability, then do you see higher risks of patients in those facilities than, for instance, having serum potassium greater than 5.0 or greater than 5.5. So I was just wondering what that relationship is then between higher serum potassium facility potassium variability and the odds of patients in those facilities being more likely to have hyperkalemia, for instance, if you guys have had a chance to look at that at all.
Yeah, in the table, demographic table, we can see that the variant for serum potassium is larger in those facilities with higher potassium variability, right? Yeah, I think, yeah, you're right. The background why we want to look into this field is that because our program, DOPPS program, want to seek the relationship between practice patterns and clinical outcomes. And in recent years, I think hyperkalemia rose a lot of attention, yeah, in this field. Yeah, and we in our practice we found yeah, clinical practitioners did pay more attention to individual potassium values. But I think they haven't recognized the management for facility levels as a whole. Yeah, management is also very important. So this is yeah, our yeah, that's why we want to do this research. Right.
Yeah, no, yeah, it's excellent, and it's very interesting. A number of years ago, we looked at hemoglobin variability, facility hemoglobin variability, and similarly there, we found that facilities that had greater variability in their hemoglobin levels across the patients in the facilities also had higher risks of mortality as well, irrespective of the individual hemoglobin level that a patient had. So, well, thank you so much for these great projects that you're carrying on, and these novel insights that you're providing, and it's just been wonderful working with you and the whole team there in China. So thank you. I'm going to ask Angelo then, I guess next. Angelo, it's such a interesting project going on regarding red blood cell transfusions, and I was curious as well that in incident patients, if you've seen higher rates of red blood cell transfusion rates, and if so, if that differs depending whether a patient has seen a nephrologist for a number of months prior to starting dialysis. And so the impact of pre-SRD nephrology care on that. I was just curious whether you guys have had a chance to look at that or not. Yeah, I'm sorry, we can't hear you right now, Angelo. And I'm usually the person who has the problem with the audio. I'm sorry. Well, how about if we go to Junwei, and then Angelo, if you could see if maybe you might be able to fix your microphone, the audio, though I know it can be a real challenge. And maybe Danielle, if you might have any suggestions for Angelo. Okay. So Junwei, how about if we switch to you? Junwei it's just been one of our greatest analysts for so many years in the DOPPS program, and just carrying out so many amazing studies with all of your great analytic skills. And it was such an excellent presentation that you gave today on E-tail calcitide. It's really striking, among the patients who discontinued E-tail calcitide, then it looks like PTH control was much better before discontinuation, and then after discontinuation, PTH levels really increased, despite the fact that it seems, at least one has the impression, that many of those patients are switching onto cinacalcet. And I was curious, do we know for those patients then who are switching from etel calcitide onto cinacalcet if they are being prescribed daily cinacalcet, or maybe instead, maybe they're getting thrice weekly cinacalcet, which we know is off-label, but is being used by a number of centers. And so I was curious why the control of PTH appears to be much poorer after those patients then switch onto cinacalcet. Yeah, I'm sorry we can't hear your audio either.
Maybe rejoin the app. Yeah.
I can hear you. Yeah, Jinju, you sound great. Yeah.
Jinhui and then, yeah, Angelo. Yeah, quit and rejoin, maybe it's better. I tried that.
So did you completely close out and then rejoin? Is that what you did, Jinju? Yeah.
Right.
Ah, Junwei?
Yeah, I can hear you.
Ah, there, we can hear you now, Jinju.
The
Junwei.
who switched to cinacalcet, they mostly have 3 times so per week.
Is that right? So most of them are getting thrice weekly cinacalcet.
Yes.
And maybe that's one of the problems here, is that when they're switching to cinacalcet, if they're only getting thrice weekly cinacalcet, maybe it's just not enough. Whereas, you know, getting thrice weekly etel calcitide IV, and etel calcitide is approved that way because it's a stronger drug. It's being much more effective. Whereas cinacalcet being given thrice weekly, which is off-label, maybe for these patients, it's just not being effective enough. And then their PTH control is much poorer. So thank you. That's really helpful to know.
Am I working now?
Yes, you are. Great. It's nice to have you back. Yes. Since we only have a minute or so on, so then, Angelo, how about if I ask you
Did you want me to just answer the question
Yeah.
I did not get a chance to answer?
Right.
Earlier about
Yes,
the
if you could do
incident
that,
dialysis
that would
patient.
be great. Okay.
Sure. So yeah, so this is definitely a key strata that we're interested in, and we have investigated how transfusion rates vary from the incident dialysis period, you know, over the first couple 2-3 years. This is a big focus of the ASN abstract that we just submitted. So we're waiting to hear the news there. I can share the highlights of the abstract, which is that we did find considerably higher transfusion rates in those first 90 days after the transition to hemodialysis. And to your question about what are the reasons for that and what that has to do with the amount and length of pre-dialysis nephrology care the patient received, that's something we are actively looking into to try to better understand why the transfusion rates are so much higher in that volatile period in the first 90 days of hemodialysis.
Excellent. Yeah, I was curious as well, you know, during those first 90 days, you know, patients typically come in with low hemoglobin from stage 5 CKD. And how soon is the decision made actually to provide a blood transfusion? Do you, so I was thinking a cumulative incidence kind of curve during that first 90 days could be interesting to get a sense of, well, how long as a clinician do you evaluate whether the patient is responsive, for instance, to EPO, and that patient's hemoglobin will respond, or are they inflamed or have other or have low iron levels, et cetera, that are really preventing you know, a robust enough rise in hemoglobin. And so when is the decision made then to start when do you start seeing transfusions really occurring then during those first 90 days? I think would be interesting as well.
Yeah, certainly. And narrowing it down to those first 90 days may still yet be too broad of a category in better understanding, in those first 90 days, is it actually that most of those transfusions are occurring in the first 60 days, the first 30 days, will be certainly useful to investigate.
Yeah. Well, thank you so much. Each of your talks were just so informative and a lot of really exciting work going on. So I know we have to move on to our next session, and I just want to thank all of the speakers and all of the attendees for your thoughts. And please, if you have additional thoughts regarding any of these talks, always feel free to drop a line in the chat. So thank you very, very much to everyone.
Thank you.
And Mark, it's my pleasure to hand the baton off, or the mic off to you over there in Stoke-on-Trent. And thank you very much for moderating our PDOPPS session.
Fantastic. So thank you. I'm very happy to be here.